Hello, and welcome to today's webinar titled Strategy for HCV Testing and Linkage to Care in and from Jail. My name is Alyssa Kittless, and I'm a manager in NASTAD's Hepatitis program. I'm going to talk more about NASTAD and the work we do around hepatitis momentarily, but before we get started, I just wanted to go over a few housekeeping items and let you know how you can participate in today's webinar. I feel like you probably have figured it out by now, but if you are not wanting to connect over the computer audio, there's an option to call in, and we've listed that phone number as well. And just wanted to let everyone know that the attendee lines are muted during the webinar. Everyone's going to be on a listen-only mode. So if you have questions or want to talk about anything, share what you're doing in your jurisdiction, the best way to do that is via the chat box. And as I mentioned, you can submit questions in the chat box throughout the presentations, but we'll be covering those in the Q&A portion. We should have about 10-15 minutes at the end to have a discussion and answer those questions. And finally, today's webinar is being recorded. And after this webinar, you'll receive an email with a link to the recording as well as an evaluation link. So if you're able to participate and share your thoughts about the webinar and your ideas for future conversations we can have related to hepatitis testing, that would be great. So today's webinar came about because I've been receiving a lot of different questions and emails about how people are approaching hepatitis C testing and linkage to care in correctional settings. And we wanted to start this as an ongoing conversation about how public health, community partners, jails and prisons, and others can really work to ensure that people living with hepatitis C have access to a cure. And we'll hear more from our speakers today, and I think most of you know that incarcerated or formerly incarcerated individuals bear a disproportionate burden of HCV, with current estimates of prevalence in jails and prisons really ranging from 12 to 35%. And despite this high prevalence, most inmates are unaware of their status. So screening and linking within incarcerated settings is really important for the health of the individual, but also as we start to work towards elimination of hepatitis C. And we know that there are a number of unique challenges to both working in jails and prisons. And so today's webinar is really focusing on testing and linkage in and from jail. And then we'll have a follow-up webinar later in the summer focused on prisons. And we know that there's just a huge range in terms of the institution and the structure and how that can really affect the way that testing and linkage to care, how it plays out and what it looks like. And so our goal is to provide a number of examples of models and ways that people are approaching these efforts. And hopefully you can find some useful nuggets of information that you can take back to your work. So I know that there's a lot of information to be covered, and I won't spend a lot of time with the background on logistics, but I did notice that there are a lot of people joining us today from non-health department partners, so I wanted to take a minute to tell you a little bit more about NASTAD and the work that we do here. So NASTAD is a nonpartisan, nonprofit organization that represents governmental public health and HIV and hepatitis programs both in the US and globally, and our ultimate vision is to see a world free of HIV and hepatitis. And we work towards this goal through a number of different ways, such as advocacy, capacity building, and social justice work. And a lot of the work that we do is in coalition and through leading coalitions. And one of the coalitions that we lead is this group that is hosting this webinar. It's called the Hepatitis Testing Partnership. And this is a group of stakeholders that are committed to and working together to increase the access to testing and linkage to care for hepatitis B and C. And we do this through both an here we haven't engaged with yet. So I'd love to get an idea of who is on the call. So we're going to open up a poll to hear where you're coming from, and the choices are health department, community-based organization, federally qualified health center, national nonprofit, Department of Corrections, or other. So if we could just take a few seconds to fill that out, that would be great. Perfect. So it looks like a large number of health departments and some community-based organizations, federally qualified health centers, and also other. Perfect. And if you wanted to share where you're coming from, if it wasn't represented, feel free to share that in the chat box at any time. So thank you so much for responding to the polls. And as I mentioned, we're joined today by 4 really excellent speakers, so I want to make sure we turn it over to them to get us started and they have enough time to share more about the work that they're doing. So today we're joined by Dr. Matthew Akiyama, who's an assistant professor of medicine at Montefiore Medical Center and Albert Einstein College of Medicine, who will get us started. And after Matthew presents, we're going to hear from Candace Gibbons, who's a bridge counselor at Durham County Department of Public Health in North Carolina, as well as Jawan Pierce, who's the executive director of Minority Health Consortium, a community-based organization that does HCV and other HIV and STD testing in Riverside Jail in Richmond, Virginia. And then finally, we'll hear from Mandy Altman, who is the Correctional Health Program Manager at the Hepatitis Education Project, and she will tell us more about the National Hepatitis Corrections Network and what resources that are available through this group. And that's a really important network because that's actually how I met Matthew and how he got to join us today. So we're grateful to have opportunities to come together and discuss through that network. So I'm going to turn it over to you now, Matthew, to get us started.
Thanks very much, Alyssa, and it's really a pleasure to be here with all of you from such a diverse range of backgrounds. And I'm going to be presenting results from a study we recently completed entitled Implementation and Evaluation of a Care Coordination Intervention for Patients with Hep C Following Release from the New York City Jails. So by way of introduction, Alyssa mentioned some of this already, but we know that there is a disproportionate burden of hepatitis C in the criminal justice system as a result of the interrelationship between high-risk behaviors and incarceration, to the point where the last national prevalence was estimated to be 17% antibody prevalence. Hep C management in jail settings is quite challenging, in part because of short lengths of stay, which on average are 14 days or less in jail settings, so it often doesn't afford time to provide treatment if treatment is available in the first place. However, there are high volumes of detainees passing through U.S. jails. 1/3 of incarcerated adults at any given time in the U.S., which is around 731,000 individuals, are incarcerated in jail settings. There are 12 million admissions per year, which is 19 times the number in state and federal prisons. So this does pose distinct challenges, but it also affords the opportunity to provide Hep C screening and linkage to care following release from jail. So what do we know about linkage to care following release from jail? So far, there are few existing data. There have been a couple pilot studies published from Rhode Island and North and South Carolina, outlining a variety of intervention components and citing linkage rates in the order of 17 to 50%. Again, these have been pilot studies, so the overall rate of linkage sort of remains to be seen following release from jail settings as yet, and more data are needed. There was also an interesting study published from the Wisconsin prison setting looking at a different marker of linkage to care than a visit with a Hep C provider. They looked at Hep C RNA or genotypes within 6 months of release as a proxy of linkage to care. And in a 5-year period of 1,600 individuals released from prison, only 9% of individuals engaged in Hep C care. So we can see that jail settings, prison settings alike, there is a big need for scaling up linkage to care services following release from correctional settings. So the objective of this study was to assess the impact of a transitional care coordination intervention on linkage to Hep C care and to determine barriers to and facilitators of linkage to Hep C care following release from jail. The setting is the New York City jail system, so there are 10 facilities, although there are one closed recently, and there are active efforts to close some facilities on Rikers Island, and 4 borough facilities in the New York City jail system. The number cited here may be less at this point as a result of active efforts at reform, but an average daily census of approximately 10,000 and more than 60,000 admissions per year. At the time of study initiation, there was an existing robust HIV transitional care coordination program, but no specific program as of yet to address hepatitis C. This was a one-armed clinical trial We enrolled between May of 2015 and April of 2017. We included individuals who are greater than 18 years of age with chronic Hep C and an anticipated release date permitting follow-up within the study period. We excluded individuals who were unable or unwilling to sign consent or who were anticipating transfer to prison, as well as those who were HIV infected, because we really wanted to look at the cascade of care following release from corrections for Hep C mono-infected patients. Our care coordination intervention involved a needs assessment, Hep C education, discharge planning by a jail-based transitional care coordinator, appointment scheduling with a target appointment date within 2 weeks of release from the correctional setting, study coordinator providing their contact number in the form of a business card for the detainee to take with them. And then, so that was all in the jail setting. In the community setting, we provided reminder phone calls, appointment accompaniment by a community patient navigator after reentry. Our primary outcome was linkage to Hep C care within 180 days of release, so 6 months of release. Secondary outcomes included Hep C treatment initiation, treatment completion, and sustained virologic response. We assessed predictors of linkage to care using the Addiction Severity Index at enrollment, which includes domains spanning medical, employment, drug and alcohol use, legal status, family and social support, and mental health. We determined significance using chi-squared and Fishing's exact tests, and we also used a software package called EventFlow, which was used to visually inspect our data and identify relevant temporal event sequences, and I'll present data using that software in 2 slides from that. Our study flowchart, so we approached 185 detainees in the New York City jail system for eligibility. 21 were found to be ineligible and 59 refused, leaving 105 who were enrolled. 5 were subsequently excluded because they were found to be HIV positive, and that left a cohort of 100 who were followed during their indexed incarceration. Of those, 8 were transferred to prison or another jurisdiction, 4 remained in jail at the time of study completion, 2 were treated pre-release, 1 cleared their viral load, and 1 died pre-release, leaving a cohort of 84 who were released from their index incarceration and who comprised our reentry cohort for this study. Some feasibility data, so the mean duration of time between enrollment and release was 71 days. On average, 3.8 participant contacts were attempted. That resulted in 42 participants being successfully contacted. That was only 50%. On average, 2.7 participant next of kin contacts were attempted, and we were only able to reach 63% of participants next of kins. Our primary outcome in terms of linkage to care within 180 days was achieved by 26 study participants, which was 31% within a median of 20 days. 17 initiated Hep C treatment, 15 completed treatment, and 7 out of the 9 who had 12-week follow-up data for SVR achieved SVR, which was a 78% SVR rate. Looking at our continuum of care, you can see immediately that there's a dramatic fall-off between those who were released and those who linked, only about a third linked. But we can also see that within the 180 days post-release, even more individuals were reincarcerated than were linked to care. So that raised the question as to whether that reincarceration in the post-release period could serve as a possible period for intervention and a time where we can re-engage individuals who potentially were lost to care to link them to care upon release. And I'll talk about that on the next slide. Also, you can see that there was a bit of a fall off in terms of treatment initiation, treatment completion, and again, SVR. It's a known challenge with marginalized populations trying to retain individuals in order to document their SVR. It's one thing to retain individuals who are on treatment, another to retain people who have finished treatment in order to just get a lab draw 3 months after treatment. This is the event flow plot. So it looks complicated, but I will walk you through it. So on the left-hand side, you can see a gray bar on the y-axis, and that represents the release date of all study participants in the study normalized at one point in time. And then tracking from left to right, you see a green bar, which represents the first event for those who were linked to care. Moving a little further down, you see the blue bar, which represents Hep C treatment initiation. And then further to the right, you can see the yellow, which represents the first reincarceration. And one thing that's striking is the preponderance of yellow, which is the reincarceration, which we saw in the last slide was more frequent than actual linkage to care. Again, 33% were reincarcerated within 180 days. Another thing that's striking looking at this event flow plot is that you can see that the rate of reincarceration and linkage to care was equal. 23 participants' initial event was linkage to care, and 23 participants' initial event was reincarceration. So you can see that they were equally common initial events. Looking at the question of reincarceration as a period where linkage to care can be reattempted, we saw that in our study, 3 participants were linked to care following reincarceration. So it does suggest that reincarceration is a period where active attempts can be made to re-engage study participants, but you can see it was underutilized in this study. And of note, there was no statistically significant association between reincarceration and linkage to care in the 180 days post-release. This is the demographic and associations that we saw in the study. So the mean age was between 40 and 50 years old. You can see that females were a little bit less likely to link to care. We actually oversampled females. The ratio is approximately 9 to 1 in the New York City jail system. We oversampled, and the rate of linkage was lower among females, though it was not statistically significant. You can see a preponderance of Hispanic, which is a known association in the jail system of a large proportion of Hispanic individuals with opiate use disorder. And looking at associations further down the table, you can see that the factors that were associated with linkage to care included being on methadone prior to incarceration, was predictive of linkage. Feeling supported socially was also predictive of linkage. Reporting drinking alcohol to intoxication prior to incarceration was actually negatively predictive of linkage to care. And then reporting having a primary care provider in the community prior to linkage was approached significance, but was not quite statistically significant. So our conclusions from this study are that an integrated jail and community-based care coordination program may be effective in improving timely linkage to care. We saw that those who linked within 20 days on median, which is quite quick. However, significant barriers clearly remain. Only 1/3 of study participants linked to care. We believe that a multi-component intervention aimed at increasing social support, linkage to substance use treatment, including opioid agonist therapy, alcohol use disorder treatment, and perhaps primary care could help improve linkage to care. And we saw that reincarceration, while an undesirable outcome following release from corrections, does provide an opportunity to re-engage individuals who have not yet linked to Hep C care. In terms of future directions, we intend on rolling out a randomized controlled trial entitled the HCV Accelerate Trial, Advanced Care Coordination and Enhanced Linkage and Retention Among Transitional Reentrants. And the first aim of this study will be to assess barriers and facilitators of linkage to Hep C care among the cohort that was presented here today. So in a qualitative study, we're going to ask the participants what the barriers and facilitators they faced upon return to the community were. And then we'll use those findings to tailor the existing intervention to create an enhanced care coordination intervention with the intention of using peer mentors as a key component to increase social support and improve self-efficacy. And then we'll pilot test the feasibility and effectiveness of the HCV Accelerate intervention in a randomized controlled trial. With that, I'd like to acknowledge my mentors and collaborators, as well as, of course, the study participants, other authors of this linkage study, and funders who have made this work possible, as well as other Hep C work among marginalized populations. And with that, I will turn it over to Candace, and we'll hear about some of the work going on in North Carolina. Thanks very much.
Great, thanks so much, Matthew. Candace, we're going to turn it over to you now to share more about your testing and linkage to care program in Durham County Jail.
All right, thank you, Alyssa. Thanks, Matthew. Hi, everyone. Again, my name is Candace Gibbons. I'm a Hepatitis C bridge counselor here at the Durham County Department of Public Health, which is funded by an industry-funded grant through a partnership between the Health Department as well as UNC Infectious Diseases. I'm on this slide here, so I'll talk to you a little bit about the testing that we do in the jail. So here at the Health Department, we oversee the jail medical contract, which is overseen by our medical and laboratory director, Dr. Arlene Senia. And so the screening in the jail is conducted by our health educators, which are you see pictured here on the slide. And we do have a division of community health educators that go into the jail, 5 days a week and conduct testing with inmates. They do opt-in screening. So if similar to what you can see in the slide here, they go into the pod and inmates are allowed to opt into the screening process. They also screen for other STDs, including syphilis, HIV, gonorrhea, and chlamydia, in addition to hepatitis B. So the screening takes place in like a multi-purpose room, which you can see in the back of that picture there, where the inmates are able to go in and meet privately with the health educators and do screening. Health educators also conduct post-test counsel. So right now, our hepatitis C testing is supported by the state of North Carolina. And so once those results come back, the patients are post-test counseled by the health educators, and then they're referred to me, the bridge counselor. Up until November of last year, we were operating on an outside-only referral system, so which meant that the health educators would do the counseling and then forward me the information, and I would contact the patients after they were released. I did not have contact with the patients while they were in the jail. We've since moved into a different model where it's an inside-out referral model where I'm able to actually go before release, and I'll talk a little bit more about that. Okay, so this is just a breakdown of Hep C patients that are tested in this focus project in December of 2015, with me coming on board in March of 2016. We've identified over 200 chronic Hep C patients, and right now they make up over 35% of my current caseload. They're 80% male, as well as nearly 60% Caucasian, 35% African American, and just a few Hispanic and Asian inmates as well. We've linked approximately 50% of those patients to care. Linkage is defined as a meeting with me, the bridge counselor, where I conduct a psychosocial assessment with them, as well as go over their drug use history, their stability, their employment, just general information about the patient, and then I comprise all this information into a referral. Patients also have a meet with a primary care provider, as well as a specialist. And then in some cases, patients are transferred to a North Carolina prison where they are managing and treating Hep C for some patients. Over 25% of the patients that are tested in the jail are lost to follow-up. So meaning that after they are screened, they're unable to be contacted after diagnosis. And, I'm kind of preaching to the choir here, this pretty much is consistent nationwide. And with my overall caseload, jail testers make up of over 60% of patients who are lost to follow-up overall. So I have a caseload of nearly 600 patients right now, and the majority of those who are lost were tested in the jail. And then I also just wanted to note that we've had 5 patients pass away after screening. So some of those cases are due to overdose or suicide. So we've lost 5 of those patients that were screened in the jail. Next slide, please, Alyssa. Thank you. And so something very secure, again, follows a nationwide trend. It's increasingly difficult to link patients who are tested in jail settings, and that's just simply because there are a lot of times they have competing priorities with housing, income, reunification with their families, substance abuse or mental health needs, as well as other health comorbidities that may prevent them from establishing care with me. As well, again, we have a high loss of care rate amongst this population. And so that really, encouraged us to kind of sit down with the health educators about a year into the grant and really kind of brainstorm some new strategies that we could use to address the low linkage to care rate with this population. Next slide. And so some of the new strategies that we came up with was we really advocated for to get access to these inmates. Again, about a year and a half into the grant, I did not have access to the jail. We were only meeting with the patients after they were released. And so this posed a problem because we were losing patients, phone numbers weren't good, and things like that. So we really advocated for me to get access to the jail. So I currently do have access to the jail. We started this about 6 months ago, where I'm able to go in with one of the health educators and meet with patients in the jail setting, and to really build that rapport with them prior to them getting released. We can go over questions that they may have about Hep C, their expectations of the process, as well as kind of get a head start on some of the barriers that they may encounter when they're released, such as housing, instability, as well as phone numbers and things like that. We also advocated for the need for an additional bridge counselor. You know, I would like to think of myself as Superwoman, but that doesn't always transfer. And so we, because we have such a high caseload now, we really wanted to bring on some additional help. So we do have a bridge counselor who's actually starting this upcoming Monday, yay! So who's going to help us with the Linkage to Care process so that I can dedicate more time to this population, because it is such a transient population. We also just really wanted to get pinned down some additional contact information, hangout spots, places where we can find these folks after they've been released. Again, that was a big problem for us in the beginning, not being able to contact the patients, phone numbers being bad and things like that. So I'm able to kind of meet with the patients and go over a lot of their history or where they might be when they're released. I also utilize a VineLink system. I'm able to follow the tracking of these patients. So I'm pretty much notified in real time of when they're released. So that's been helpful as well. Another strategy that we came up with is to create a jail resource page, which consists of mental health resources, information about PrEP, information of where they can find me when they're released, as well as information about our safe syringe and naloxone program. So this jail resource page is a one-page sheet that we drafted, and it's placed into the belongings of all of the inmates, whether they test positive for hepatitis C or not. So they're able to go home with this resource page when they leave the jail. So it's just an additional information for them. We've also came up with the idea to come up with hygiene care packs. So we have toothbrush, deodorant, toothpaste, basic things like that, which a lot of people don't have when they're getting released from the jail system. So I'm able to provide those to those patients, as well as bus passes and other things that they may need in their transition. We also really advocate for our naloxone and safe syringe program. We recently rolled out our safe syringe program here in North Carolina. I'm here at the Durham County Department of Public Health back in April. So patients, you know, a lot of times when they're, just because someone has gone to jail doesn't necessarily mean that they're ready to stop their use or that they're ready to engage in treatment. So we really have to think, you know, broadly when we're thinking about ways to engage this population. So a lot of times, I may not necessarily be immediately helping them with getting to a provider. We have to start where the patient starts. So we're advertising, as well as our safe syringe program and the naloxone program, where they can come and get clean needles, fentanyl test strips, and things like that in case they need it. Next slide, please. And I just really want to, you know, acknowledge my focus team here at the health department, as well as the health educators who really go in and do the legwork with these patients. They meet with them daily. A lot of times they are my bridge with them, and so I just want to acknowledge those, as well as the jail staff and Liz Malice, which is our focus regional lead for the Carolinas. Thank you guys, and I'll be sticking around until the end of the webinar to answer any questions.
Great, thanks so much, Candace. So we actually are going to transition slides quickly, and while we do, oh, it didn't work, okay. So, no, excuse that, we're not going to transition slides. But before we turn it over to Jawan, I just had a quick question that came in for you, Candace. Do you screen for chlamydia and gonorrhea orally and rectally, or just through urine in the jail setting?
So we do a urine screening where the patients, so they come, they get the equipment that they need, and they go and give the collection in their cell, and they bring it back to the health educator, and we take that back to the health department. So they have what they call a mobile fat max kit that has complete phlebotomy in the kit, where they're able to collect everything that they would normally collect in a lab setting. So it's
Okay.
a guarantee.
Perfect. Thanks for that follow-up, Candace. So now we're going to turn it over to Joanne Pierce. And Joanne, just to note, we're having trouble inserting the slides that you sent me, so I'm just unfortunately going to just have this as a placeholder, and then we can include the slides that you shared in the final slide deck, and that way people can access it after the webinar. And I just apologize for that, but we're going to turn it over to you, Joanne, to tell us about all the great work you're doing in Richmond.
All right, thank you. Good afternoon, everyone. My name is Joanne Pierce. I'm the Executive Director at the Minority Health Consortium in Richmond, Virginia, and we are funded by the Virginia Department of Health. The Minority Health Consortium has been testing at the Riverside Regional Jail, which is located in Prince George County, Virginia, which is about 28 miles south of Richmond, Virginia. And it houses inmates from about 7 different counties and cities in the central part of Virginia. And it has the capacity to house approximately about 1,250 inmates at one time. We began doing HIV testing at the Riverside Regional Jail in December of 2004. And as time went by, we kept looking at the risk assessments because we had questions on the risk assessments about people's injection drug use, whether or not they knew, suspected, or had been diagnosed with Hep C. And we kept seeing repeatedly that there was a high self-reporting of injection drug use, jailhouse tattoos, and we kept saying to ourselves, we wish we could have funding to do Hep C testing. But as time goes, we were patient and we just kept looking at the data. And then one day I got a call from the Virginia Department of Health, and they said, hey, it's a possibility we could get some funding to do rapid testing. Do you think the jail may be interested? And I went to the leadership at the jail and I talked to them. And, it took about a year of negotiating back and forth. And finally, they gave us the go-ahead to start doing Hep C testing in the jail. And we thank them so much for that. We started doing our Hep C testing on December the 8th of 2015. And we did a 3-day stretch. We conducted 77 tests over a 3-day period. So since we began in 2015 up until February of this year, we enter the jail 3 times a year. We come in the second week of February, the second week of July, and the second week of December. And since we started the Hep C testing in 2015 up until February of this year, and I just wanted to show you the irony of this whole situation is I told you we go 3 times a year. So since we first launched the testing in 2015, we've made 27 visits into the jail to do Hep C testing. And out of those 27 visits, they have yielded 506 hepatitis C rapid, 568 rapid tests. 417 of those were negative. 149 were antibody positive. We don't have the RNA totals on those, and 2 were unknown. At our last testing event in February, we tested 82 people. 47 tests were negative. 35 were AB positive. And of the 35 that were positive, 11 received confirmatory testing, and 8 were RNA positive, and 3 were RNA negative out of the 11. And some people had been released between the rapid testing event and the confirmatory draw, so we don't have their RNAs. But the inmates really respond well to the test. When we put the information out ahead of time, the jail puts in a sign-up sheet in all of the housing units in the regional jail, and the inmates are given a risk assessment where they look at the different criteria that may put them at risk for hepatitis C, such as being a baby boomer or injection drug use or tattoos that are done not in a professional parlor or tattoos that might be done in a jailhouse setting. And they determine whether or not they feel may be at risk. And so they sign up, and then the jail provides us with the list on the day that we come in to do the testing. We go pod by pod. And on some days, because sometimes inmates have come in since the list was passed out, maybe the month ahead, and they have open calls. So when the inmates their name may not have been on the list for sign up, but they do an open call in the pod, and those guys are allowed to come out for the HIV and Hep C testing. But before we do the Hep C testing, we screen them. We ask them questions about, whether or not they'd ever been diagnosed. And sometimes, people tell you no. And sometimes inmates they don't tell the jail medical department that they had Hep C when they come into the jail. And some people think that I'm going to take this rapid test, maybe my Hep C is gone, maybe cleared itself. So you do have some occasions where a person may know their status and they just want to find out if it's still there. But for the most part, they really enjoy it. And we use the time while the guys are waiting to get their test done to do like a little Hep C 101. So we have them all huddled in the gym. And I tell them, I said, this is your time to ask us any questions you might want to know about Hep C. I explain to them how the test works. And I also explain the other side of the coin is that the fact that you're in jail may prohibit your ability to be able to have access to medications. So we educate them about Hep C, and we tell them that even though you may not have access to the medication while you're in jail, not everybody needs it, but use this experience as an opportunity for a change of your lifestyle. So if you find out that you have Hep C, you may want to consider, hey, limiting or quit smoking or limiting your amount of alcohol, drugs, or giving up alcohol or drugs, but maybe a chance to educate them to change their lifestyle. And another great opportunity for us is that the administration at the jail, they allow us to bring magazines. You know, most jails and prisons don't allow you to bring magazines off the street to inmates. But I met some of the editors for PAS magazine and the Hep C Guide magazine at an INMAC conference a few years ago. And I told her that I was about to embark on testing in the jail for the Hep C and that we were doing HIV testing. So she sends me extra magazines during the year. And the only requirement that the jail has of us is that we have to physically remove all the staples out of the magazine. So we take, every time we go into a testing event, we dump anywhere from 400 to 600 magazines to include the Hep C Guide, the Real Health magazine, PAS magazine, Positively Aware, Plus magazine, and the HIV medication guide. So we have an opportunity to educate the inmates who are getting tested, but we tell them to take as many of the different magazines as they want. And when they finish reading them, to share them with another inmate in their pod. And so each time we come back, the inmates have shared this information, so they basically are recruiting more people. So when we come back in, we're going in July, we'll be there the second week of July. So when we come back in December, people back in the pods who may have not come out, but they have access to these magazines that we've distributed within the jail network, and they become more educated and inquisitive. So they may want to take the test when we come back in December. So that's been working really well for us. And of course, we have them fill out risk assessments. We have them fill out risk assessments and fill out consent forms for testing them in the jail. And once they're released from jail, some of them go on to federal prisons or state prisons. But once they're released to the community, we also give them our card with our contact information on it. And they took their test, so we tell them if you get released from jail and you're having trouble trying to find a health provider or get linked to the Affordable Care Act or primary care, that about office and contact us, and we will help navigate them to the different services that they might need to get them linked into care if they need care for their Hep C or any other health issue they may be dealing with. And so in the future, we're going to start teaching classes. The administration is going to allow us to actually start coming in on a regular basis and educating the inmates about hepatitis C and sort of like breaking it down for them so that they have a full understanding. And hopefully that will help us to recruit even more persons into wanting to take the hepatitis test. I think I've just about covered everything, and so I'm going to turn it back over to NASTAD.
Great, thanks so much, John. We really appreciate that overview of the work that you're doing, and I know a number of questions have come in during the presentation, so it looks like we'll have a good amount of time to get to those following Mandy. So Mandy, I'm going to turn it over to you to share a little bit more about the National Hepatitis Correction Network and all the great work you're doing and how you're bringing people together and how we can access these resources and support to address the questions people are raising and others that they're having while looking at responding to hepatitis in their jails and prisons. So it's all you, Mandy. Great, thanks, Alyssa. And thanks everyone for letting us have a few moments to speak about the National Hepatitis Corrections Network. The NHCN is an initiative of the Hepatitis Education Project, which is a nonprofit in Seattle. And we formed about 6 years ago the network because we realized that a lot of states or jurisdictions aren't really speaking to each other. And obviously this is a kind of a siloed environment where things are rapidly changing. So we kind of aim to get everyone on the same page and talking to each other. So we do a lot of professional networking. Our biggest event, which I think a lot of participants on this call may have already gotten involved with, or if you haven't, then you could next year, is we have an annual meeting. Our meeting next year will be on March 20th, 2019 in Las Vegas. And we have somewhere close to 100 participants around now who are able to receive scholarships to come from both prisons and jails and just talk with each other about the different testing and treatment policies within jurisdictions and get ideas on how to better purchase drugs or how to change the policies within your system. Besides that, we also, like Alyssa, have webinars throughout the year. We have professional calls where we get doctors or nurses on the phone with each other to talk about their policies. We have a newsletter that we send out, and I know Alyssa was going to share my email address at the end of the call, so we're happy to let anyone sign up for our newsletter, or we're happy to link anyone together. We have a huge database of professionals around the country and some international, so if someone's trying to reach out to a certain place, it might be a good first step to ask us if we already know someone, and we can help try to link people together. But besides that, I only wanted to give a really quick overview of the NHCN, but we're here to answer questions. And also just an FYI, besides the network, HEP also does education about viral hepatitis in the prisons and jails in Washington. So I'm also more than happy to offer my experience working with those settings as far as educational programs if anyone has any questions. But besides that, I'll hand it back over to Alyssa. Great, thanks so much, Mandy. And I shared your email address in the chat box so everyone can find it there, or if you for some reason don't see it, you can always email me and I can connect you with Mandy directly, because the National Hepatitis Corrections Network is a great resource. And we have had a number of questions come in, so I want to open it up to the Q&A portion, and then just note that if we don't get to your question, we'll be sure to follow up. But I feel like we have a good amount of time now to start addressing them. And one that's come up from a few different people is, how do you get buy-in? Or have you had any pushback when trying to get into jails? And if you have had pushback, how do you kind of overcome that challenge and get buy-in within the facility to prioritize hepatitis testing and, you know, ideally linkage and access to treatment? So I will open that up to any of the speakers.
Okay, this is Jawan. At Riverside Regional Jail, because we have been conducting HIV testing there, and over the years, you know, they always feed us when we go into the cafeteria, in the employee cafeteria. So every time we go in, I would run into the superintendent, who's the warden of the jail, and I'd always check in with him, let him know we really appreciate him letting us come there. I had a partnership with the volunteer coordinator, the inmate programs coordinator, and over the years, I built a rapport with everybody who was like up the chain of command all the way up to the warden. So I had a person in the one of the captains that was in charge of the medical unit and the programs unit. You know, we had been talking about Hep C, and I sent them some statistics about, you know, Hep C was increasing, and there was a possibility that we might be able to provide rapid testing. And at this particular jail, they contract out their medical services are contracted out. And the first time I tried, I did get some pushback because one of the medical providers, he had concerns about, you want to come into the jail, and you're going to tell these guys and gals that they're Hep C positive, but how are you going to treat them? They're not going to be able to get treatment in jail. And so, you know, that was some pushback. So I regrouped and we kept working and talking, and then finally, you know, because of the rise of the opioid crises, and I think the thing that happened in Indiana was like a national scare for everybody. So I went back to one of the other captains, had become involved in it, and then he brought me back in again. And I said, hey, can I come and meet with the superintendent and the medical director of your new program? And, I wanted to have all the players at the table for the regional jail at the table, because when you get all the players in the room at the same time, including the superintendent, and then what I did is that I'm going to invite everybody from the Virginia Department of Health who were the players as far as, the hepatitis C program, and who were the decision makers were. And we all came to the table. We explained, what we were trying to do, and all the decision makers in the room, and they agreed to write up a memorandum of agreement. The health department developed a contract MOA with the jail to be able to pay for the lab work that needed to be done, and of course the strong connection that MHC had from doing the HIV testing and having built that rapport. You can't have one person missing from the planning table, because ultimately the superintendent is the head, but you got to have the medical provider on board. You got to have the people who run the inmate programs, the person who does the contracts for the jail. I had all of those people in the room, and it took almost a year to make it happen, but we did it, and we've been there, and they've really been happy with the results and everything. So you got to pull everybody into the net.
Yeah, I can add to that as well. Again, like I was saying in the presentation, we oversee the Durham County Health Department oversees the medical contract, and the PI on our grant is the medical and laboratory director here at the health department. So we really had that champion to be in those meetings and advocate not only for testing but also for linkage to those inmates. Because again, it's not something I had access for, but once we got started on the grant and was able to present the data that, hey, a lot of these patients are being lost to care or not getting the proper follow-up, once we had the data to support that, I was able to get access. So yeah, really starting with the medical director, with Arlene Senior, shout out to her, is what really got us in the jail and got moving with Linkage to Care.
And I agree completely. This is Matthew. Having medical director as well as DOC involvement is really essential. And it may seem overwhelming to introduce Hep C services, but one takeaway hopefully from the presentation that I gave is that one way to make that less intimidating is to really leverage the work that's already been done. Most of the work that's been done in this space has been related to HIV. So there may be existing HIV services that can be altered or leveraged in order to expand to providing Hep C services.
Great. Thank you so much for those really thorough responses. And I'm going to turn it back over to you, Matthew. I know there was some conversation happening in the chat box and the Q&A box, and I just wanted to make sure to pose that on the phone as well, because I know this is something of interest to the broader group. But how do you assure linkage within jail and prison? And I know you started to speak to this a little bit, so would you mind just kind of elaborating on that on the call?
Sure. So I think that, and this is open for discussion, of course, but I think linkage to Hep C care really should be defined by a visit with a provider who can provide Hep C specific services, including possible treatment if available, and Hep A and Hep B vaccination, et cetera, screening for cirrhosis, that kind of thing. But I wrote this in the Q&A to Liesl. It was a great question. Along the way, there are a number of important steps, as well as after linkage to a Hep C treating provider, that may result in increasing knowledge, improving self-efficacy, and really improving the whole cascade for patients living with hepatitis C, like counseling, support groups, discharge planning, harm reduction services, et cetera. So linkage in the correctional setting is really important, and also calls back to the fact that really collaboration with DOC is essential, and that patients don't get to the clinic in correctional settings unless DOC is involved. So having buy-in from the Department of Corrections in order to facilitate linkage to care within the correctional setting is also really important.
Great, thank you. And I had a slightly related but also tangential question. You mentioned in your presentation that one of the facilitators of linkage was people being on methadone. Do you in Rikers or New York City jails continue people on methadone within the correctional setting, or is that something that is discontinued?
So if the intention is or the trajectory is going upstate, what we say upstate is in reference to prison, then patients are detoxed from their opioid agonist therapy. But if there's a plan to release the patient back from the detention, from the jail setting, in general, opioids are offered to be continued while in the jail setting in transition to the community. That's one outcome that we really wanted to look at, and we may still try to, which is, is there an effect of being on opioid agonist therapy prior to release? And in terms of linkage to Hep C care, Jody Rich's group published recently some results showing that it does affect the cascade in terms of active opiate use disorder and overdose, and we suspect that that is the case for Hep C. We did show that on entry, being on methadone was predictive of linkage to care, so we suspect that being on methadone prior to release or Suboxone where it's available would also be predictive of linkage to care.
Great, thank you. And another question came in about if anyone has suggestions on how to bridge the gap with facilities that don't allow testing within them. So is there a way to come in and provide education or build a partnership to ensure linkage when people are transitioning out of that facility, or how have you kind of overcome that challenge of not being able to directly test within a facility?
I can speak to that a little bit. I got a lot of pushback from our state prison system when I was trying to really outline a good referral from the jail to the prison. So we really just kind of took a step back. And the individual I spoke with is saying that, you know, hey, if the patient comes in knowing their status, then we will help them manage it. They just didn't want to they just didn't want to start testing. And so we really just relied a lot on our health educators to inform patients, so to get those results into them as quickly as possible, and to encourage them that when they get to the prison system, to let them know, hey, I already know I have hepatitis C, and so then that way they can get management and or treatment. But again, in North Carolina's non-medicated expansion state, so we've got a little bit of pushback for that, but just really kind of empowering the patients to self-disclose their status before they got to the prison is what helped kind of move the ball along once they got there.
Great, thanks so much, Candace. Joanne or Matthew, do you have any other thoughts on that you'd like to share?
Well, I know for us, we're dealing with a regional jail that has, and I know some of the other people on the call, they're dealing with like State Department of Corrections and, you know, the larger prisons. But for us, ours is managed by a regional authority. And so I think because we have been so consistent with our HIV testing services over the years, that I think the trust in providing, I was able to get the statistics about Hep C to the persons who worked in the prison who were in command positions, and also to get the data to the warden so that they can see what's going on in our community. And I think because they do have a passion and know that these persons are going to be returned to society, you know, back into our communities from which they came, I think they were more apt to be willing, you know, to me, I really thank the warden for even to allow us to be able to bring the magazines into the inmates, so that I may not be able to reach each one of the inmates through verbal contact or face-to-face contact, but taking those magazines, you know, I'm dumping 400 to 500 magazines every time we come in there over a 3-day period, which is getting circulated. So that's a way of educating the inmates about it. And also, you know, the prison or the regional jail, you know, they are happy to have healthy inmates, you know, being able to be more knowledgeable about their health. And when they get to the streets, they know how to access us or how to, you know, get linked to care once they get released from the jail. But I think the most important part is finding out who the gatekeepers are, just like they tell us gatekeepers in the community. You have gatekeepers in those jails and prisons, and you just gotta, you know, like for us, we've been going in there almost 14 years, so I know just about all of the captains and all of the medical people that's in there. So the longevity of your existence, like if you have health educators going in somewhere for a long period of time, I think those relationships that they build over the years carry a lot of weight when you're trying to bring a new program. We were even allowed to do syphilis rapid testing under another grant with NATCHO that we recently completed. So that was three testing programs in one jail that, you know, for us, you know, the regional jails, they're controlled by a regional authority. So it's different from the Department of Corrections, but that's what worked for us.
Great, thanks so much, Joanne. And we only have a few minutes left, and I know we started a few minutes late, so we'll try to wrap up, and then if there are questions that aren't resolved, we can definitely make sure to follow up. I don't know, this is kind of a large question, but if anyone has some relatively quick thoughts on how to handle the issue of prisons and jails that aren't treating, and how you address concerns around testing related to treatment access and the cost of treating and things like that. Does anyone have any final thoughts to kind of wrap up? Because I think that's an important piece of the conversation as well.
I'll start. So I think that it's so important. This goes back to our first question, to have buy-in from the medical directors as well as the administrators and those who can potentially, if available, and I know this is challenging in a lot of places, to earmark funding for Hep C treatment in order to have a goal for establishing a linkage and treatment program within the correctional setting. It is a known problem that if treatment isn't available, that Hep C screening often is not done. So developing those two in tandem in this day and age, where prices are falling and will hopefully fall even further. There are also strategies for drug pricing that can lead to reductions in pricing that can be discussed with administrators and medical directors, et cetera. But everyone really needs to be on board in order to make the testing, really attack all facets of the cascade within correctional settings.
Great. I think that's a perfect note to end on. So I just want to thank all of our speakers for your incredible presentations and everyone for joining us today. I feel like this was a really rich discussion, and as I mentioned, I hope that this is the start of an ongoing conversation, both through NASTAD's hepatitis testing partnership and in collaboration with the National Hepatitis Corrections Network. So we will be sharing the recording of the webinar and also send an evaluation link. So if you're able to provide feedback on what additional pieces of the conversation you want to have through these groups, or additional ways that we can support you in your efforts, please feel free to include that information in the evaluation. Just thank you again, everyone, for joining, and I hope you have a great rest of your day.
Thank you. Bye-bye.
Thanks for joining, everyone.
Thanks so much.